Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Welcome everyone to Mountain West AETC Echo. I have the honor of doing the didactic today. There was an update to the perinatal guidelines at the end of January, last day of January, and I'll just focus today on the major updates. I won't go through all of the guidelines. I won't review the infant feeding section, which is incredibly important, but which we previously reviewed. I'll try to focus on changes and updates. This is where the guidelines can be found. So as a reminder, this comes from the Department of Health and Human Services and is the set of guidelines we turn to for recommendations on ART and other strategies to prevent transmission during conception, pregnancy, and infant feeding. In terms of choice of ART for a person who is pregnant and has never taken ART before, these are the two major updates. So again, I'm just focusing on the changes. So one, bictegravir/taf FTC has been moved from insufficient data to alternative. So it's still not on the list of preferred options, but data and experience has been growing, and there now is enough data and experience to put it in the alternative category. And if you look at the table in the guidelines that gives suggestions for what to do if a person becomes pregnant on a specific regimen, for BIC/TAF FTC, it now says reasonable to continue, and I would very much agree. I'll show you on the next slide a summary of the preferred options and then a table with all the alternative options. But that's a pretty major change. Again, reflects increased data and experience for BIC/TAF FTC during pregnancy. Really no safety concerns have come up to date with that regimen during pregnancy. The other change, boosted darunavir with 2 NRTIs, was listed as preferred. Now it is listed as preferred only in a specific clinical situation, that situation being a person has previously received cabotegravir for PrEP, then was diagnosed with HIV. We've talked about this before, and it is in line with the adult and adolescent treatment guidelines. In that situation, there is a risk of integrase resistance. So one would start with boosted darunavir and 2 NRTIs, at least until an integrase genotype showed whether integrase resistance was present or not. So that is the situation where this option would still be considered preferred during pregnancy. Again, it is in line with the adult and adolescent treatment guidelines. Otherwise, boosted darunavir with 2 NRTIs has been moved to alternative. So these are the preferred or recommended initial ART regimens during pregnancy. You can see in the first row, dolutegravir with 2 preferred NRTIs is really now the preferred or recommended initial ART regimen during pregnancy. It is an option with a lot of data and now clinical experience. And then in the bottom row, I've summarized what I just said about boosted darunavir. There is really one clinical situation where that might be considered preferred, and that's if you suspect or if there's a possibility of integrase resistance. Again, we're focusing here on choice of first regimen for a person who becomes pregnant and has never before taken ART or is diagnosed with HIV during pregnancy. Here is a summary of the quote-unquote alternative ART regimens. You can see again, bictegravir/taf FTC was moved to this category. You can see the other options, including raltegravir, boosted atazanavir, boosted darunavir, efavirenz or rilpivirine, all with a preferred dual NRTI backbone. Doravirine as a first-line option, or doravirine is an option for ART for a person who is treatment naive, is still listed as insufficient data. There just isn't enough safety or efficacy data during pregnancy yet to put it into one of the other categories. It's not a common choice for a first ART regimen for individuals who are not pregnant anyway. So again, this is pretty much in line with the adult and adolescent treatment guidelines. These are the ART regimens still listed as not recommended. I've mentioned this before, but I will reiterate it. The cobicistat boosted options really are not recommended because levels seem to decrease late in pregnancy to a point that raises risk for virologic rebound and failure and new resistance, especially with cobicistat boosted L-Vitegravir. So those options, personally, I really would encourage changing during pregnancy and not starting during pregnancy. Long-acting injectable cabotegravir pivarine is on the not recommended list, not because of documented safety concerns, but because of insufficient data to date. And we'll come back and talk a little bit more about some additions to these guidelines for cabotegravir pivarine if a person wants to conceive or becomes pregnant. In the bottom row, I've included a note from the guidelines that says that these agents you can see listed there are not recommended as initial therapy during pregnancy, and that reflects our choice of initial therapy in the setting of someone who's not pregnant as well. But the guidelines emphasize that if a person has treatment experience, has drug resistance, and they're taking these, the most important thing in that scenario is an effective regimen that's going to keep the virus suppressed, and then it may be appropriate to continue these agents despite limited data during pregnancy. The updates on the section for people with HIV trying to conceive mostly focused on considerations around long-acting cabotegravir pivarine, again noting that there are not yet sufficient data for the safety and efficacy of injectable cabotegravir during conception or pregnancy. So what's noted is that if a person is receiving this option and expresses that they wish to conceive, the ideal would be to stop these long-acting agents at least 1 year before conception. That said, I think there are a lot of considerations here, and I think the reality is a lot of people are receiving injectable cabotegravir because that is their best option to stay suppressed, and because they really struggle to take oral ART. So the decision to stop the long-acting injectables and switch to oral ART prior to conception and pregnancy may raise risk for some individuals of virologic rebound, of missed doses. So I think there's a lot to consider here. And in this situation, I think there really is a role for shared decision-making and counseling about what is known and not known about cabotegravir during pregnancy. I've not had this scenario come up in clinic for me yet, but more and more people are receiving cabotegravir. It probably will come up at some point. And I think, again, it's an area in which I would counsel individuals and try to help them stay on the regimen that's most likely to keep the viral load suppressed. The section on PrEP, periconception, antepartum, and postpartum wasn't changed dramatically. There were some changes to make this section more in line with national PrEP guidelines. There is still an emphasis that TDF-FTC is the preferred option for people who have receptive vaginal sex during pregnancy or during breastfeeding. And there is an emphasis and reminder to register with the Antiretroviral Pregnancy Registry and report instances in which people become pregnant taking ART or PrEP. That's one of the ways we get data and learn more about these drugs. So I'd encourage everyone to do that. And there are a few other updates. There were some changes to align more with the adult and adolescent treatment guidelines, including an update to the threshold for sending resistance testing during pregnancy, the definition of virologic failure, and the threshold is now listed as above 200 copies. So if a person during pregnancy has a suppressed viral load and then rebound to above 200, we would have a low threshold to attempt genotype resistance testing. There was also an update to the CD4 count monitoring section, again, to try to be more in line with the adult and adolescent antiretroviral guidelines. For example, there's a note that if a person is pregnant and you check their CD4 count is above 300 and their viral load's been suppressed for at least 2 years, there's no need to monitor the CD4 count during pregnancy. Again, the attempts were to really line up all the guidelines. Bictegravir was also added as a recommended or preferred first-line agent for treating HIV type 2 infection during pregnancy. And again, I'm not going to review all the updates to the infant feeding section. We talked about that, last spring that came out. It was major. It's still, I think, incredibly important to review and to disseminate to colleagues and other clinicians and any staff who will be helping care for pregnant people with HIV or people with HIV after delivery. But I'm not going to review it in detail here. If you haven't gone through it and you weren't a part of our conversations on ECHO, please do take a look at that. So in summary, the preferred and alternative ART options during pregnancy were updated. Dolutegravir is still preferred, but these updates reflect growing data for bictegravir TAF FTC during pregnancy. And I would say if a person would really benefit from a single tablet daily, if that's going to help adherence, then I would consider BIC-TAF FTC as an effective option during pregnancy. There were additional updates made to align the perinatal guidelines with national PrEP guidelines and treatment guidelines. And in my opinion, the updates to infant feeding recommendations remain notable and really critical to disseminate to clinicians and colleagues. But those were the major updates as I saw them. I'll stop there and happy to field any questions or comments.
Thank you for watching this edition of the Mountain West AETC Project ECHO Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.